Hello, everyone. Welcome to week 2. We are now into the swing of being back into the semester. This week, we'll be doing a wee introduction to dental radiography. You will have a separate dental course that you will be taking, and we will introduce you to dental radiography. You'll look at the machines in lab. You'll use both CR and DR. We'll do one little brief foray into film, but most people don't do that anymore. And that will prepare you for your final semester, in which you'll actually have a dental lab that is specifically just for dentistry. So let's get started. Okay, you may ask yourself, why are full mouth radiographs even a thing? Most clinics, so back in the day, as I like to say when I like to pretend I'm old, we used to do dentals, but dentals were more symptomatic of a problem. So an animal had a broken tooth, or there was a rank smell, or there was something going on. So we were kind of more doing a dental when there was a problem. Now we do a lot of comprehensive dentals as something that is good for an animal, just like it's good for people. And just like with people, sometimes it looks like everything's great on the surface, but you realize that there's so much more going on below. Just like when we talked about anatomy, remember that if you think about a tooth like a tree, what you see isn't all what you get. There's an equal amount of tooth, or sometimes more tooth, that is in behind the gum line and in the alveolar socket that we can't see unless we radiograph it. So we might want to investigate what's happening below the surface. So a lot of times, a lot of clinics now, when they do dentals, prophylactic dentals, full mouth radiographs are part of it. So look at that. That tooth looks healthy, but look at how much erosion of that root is below the surface. And we wouldn't know that until maybe the tooth broke and fell out. How do we get these dental x-rays? Well, dental x-ray machines. You can appreciate that the x-ray machines we use for full body rads or for a thorax or a limb, they're too big and awkward when we're dealing with a mouth. Now, you can do it with a real conventional machine. We've dropped that skill, but it's something I used to have to do at certain clinics where we had to use the whole thing. And believe me, you're lucky you don't have to do that anymore. So when you're struggling with your dental radiographs with these machines, just count yourself a little bit lucky. So these dental x-ray machines, the machine itself where you put your settings is on the wall. And then we have this fabulous articulating arm that can bend, and a movable tube head. So you can appreciate that you can get a lot of range of twisting and turning to get all of those views of the various teeth. The collimator cone has no collimator light, so you don't have a light on it. And we're going to teach you basically how close you get that tube head is going to be how focused it is. So the further you get away, the more those x-rays, and remember, are going to come out in the cone shape. So you'll actually get a bigger focal area. The KV preset's usually about 70, and the MA preset is usually about 7 or 8 MA. Seconds is the variable that we get to change. Now, most machines have preset settings for incisors and canines and premolars and molars. So you set the tooth, and that's what the machine's going to do the rest. Okay. We're going to have this conversation right now because it happens every time, and Kathy and I will be on your case after you practice because we're going to do a series of runs of practicing on skulls this semester to practice with the machine, and invariably everybody always forgets to log, right? So you've got to still log them. They still count as x-rays because x-rays have left the machine, so they have to be logged. We do have a separate dental x-ray log that you'll be filling out. Don't worry, we'll keep reminding you. Film. Like I said, you're not going to deal with film. We're going to do it once. The film itself there's no intensifying screen. The film is sandwiched between paper, and there's a thin lead sheet on the back of the film, which is hazardous waste. It's a little bit tricky sometimes when you're in the dark trying to figure out what's the film and what's all the other bits. That thin lead sheet prevents radiation from going through the film, and it's enclosed in a plastic wrapper. There's D and F speed film, so D is slower, it's more common, and F is faster. Less exposures, but more expensive. So you can appreciate most clinics would get D film. Now, I've worked in places where we did film, and I filled up little urine sample cups and with our fixative, our developer, um, and all the chemicals in there, and you would sort of just like you're dip tanking. Um, you can. Were little like automatic processing machines. You can see here above, that's what we call a chair side dental machine. So you can actually be out in the light because you put your arms through those little black cross-hatched inserts, and you're going to dip along as you go to develop your film. So you're going to get a chance to do that at the beginning of the semester. But you do need rapid processing chemicals, and you can appreciate it's a small little cup, so it becomes contaminated quickly. So you have to always be um, changing those chemicals. Most clinics, you're not going to see this though. They've gone digital. When I was near the end of my practice time, I'd say 50% were digital. Now I don't know of really anybody that does radiographs of teeth that haven't gone to a digital system or CR. So you can see that we have examples of film. The film to the left is actually traditional film. So you can see that it's kind of a bluey green or robin's egg blue. You would pull that tab once you have it in a safe, dark area to expose that film to process it. Comes in different sizes, 0 to 4, 0 being the smallest, 4 being the largest. And as you're going to learn going on, the size is really dependent on the tooth you're taking and the size of the animal and how you can fit it in the mouth. Remember, those pesky pallets get in the way sometimes. On the film, you can actually see there's a dot. And what that dot does, that dot is to go to the front of the mouth. And that dot helps because it shows up on the film when it's processed. And what it does is it helps you locate. So that dot always goes to the front of the mouth. So you know that's the rostral aspect. So when you have all your films taken, you can realize which ones are at the front, which ones are at the back, and then you'll also learn about maxillary and mandibular. Off to the right, we have film, but it's not traditional film. What it is CR plates. So CR machines, like we learned last week, or kind of like a hybrid, I like to think, between film and DR. So instead of a direct digital image, you're going to take an X-ray on the plate, but then you have to put it through a processor. Instead of chemicals, it's going to use that excitable light and come up with an image on the computer. Now, they don't have a dot, but what they have is an A. And it's really important, first of all, that you put the right side of the film towards the tube head, just like an X-ray cassette. And also to make sure that the A is at the front of the mouth so that we can locate. That's just kind of a standard language that we do. And again, we have every size from 0 to 4. Once you take the X-ray, you run it through the processing machine, comes up with the image, and it also wipes off that image so that you can take another one for the next shot. Okay, so I've kind of already talked about this a little bit. Digital systems, the CR system. So that's what the processor looks like for those CR plates. So we have the PSP plates, like they're film-like, size 0 to 4 that I talked about. And you put that plate once you take your X-ray through the scanner. And it's going to read it, come up on the computer, and clear it for the next view. We'll look in lab. You can see that to fit it through, you need to make sure that you put it through a guide so it doesn't get stuck. And there's different guides for each size. The other side is you have to have this rule blue to black because if you put it in backwards, you're not really going to get a good image. The DR system is our digital. So like our digital machine that we use for our whole body, but it's really small. So the one we have is a size 2 plate. Most clinics will only get one size because it's really, really expensive. Now, They're wired directly to the computer. They are so handy in the sense that you can immediately get an image. And if you don't like the way your image is set up or the angle, you can adjust it because you can leave it in the mouth. Now, they're harder to work with because you've got that pesky cord. They're not flexible at all, so they don't flex in the mouth or bend. And there's this dead zone around the outside of the plate so the plate isn't actually even the size too. You've got a little bit of space that nothing comes up on. And they're hard, so it's hard to fit it in the mouth. So it's harder to work with, and it's really costly. So we're going to read you guys the riot act about never dropping it on the floor, because if you wreck it, it's very expensive to replace. So when we do dental radiography, most of the time we're doing an intraoral technique. Just like when you get dental x-rays done, they're putting the film in your mouth. Now, our patients are going to sit there and go, open your mouth. Okay, stand here while I take this x-ray. So they're going to have a general anesthetic because we're putting a plate in their mouth and we need them to stay still while we take the appropriate angle. This is where you're going to be frustrated with dental radiography. Every set of teeth have a different technique because we need to get that root, and because of the palate and the shape of the teeth, you're going to have a bunch of different techniques in order to tackle dealing with getting a good view that's not elongated or foreshortened. Right? So the film is actually placed inside the patient's mouth. Like I said, how to identify the film. Films are too small for a left-right marker. Each film, if you're doing traditional film, has a raised dot with a convex and a concave side. The convex side always faces the tube head, right? So the bump out, and it goes to the rostral end of the mouth, right? So convex, the bump is out. On digital film, it's the A. The A will face the tube and is rostral. So you can see here, there's no A, this was a film, but that little dot is showing you that's the front of the mouth. Now you're probably like, duh, there's a canine tooth, right? And we're working backwards. When you're dealing with something like a premolar or a molar, you might not 100% know exactly where you're located. So that dot and that A is going to be very handy. When you're actually viewing your films, whether it's digital or CR or film, we want to orient them properly, because when our veterinarian says, and you actually you're going to learn, you can mount your full mouth rads, and there's templates that you can do. You want them mounted in a certain orientation so that when the veterinarian looks at it, they know right away, these are mandibular, these are maxillary, these are the order of the mouth. So you want to view it the same way it was placed in the mouth, so convex side facing you. Determine maxilla or mandible, so which one's which. Well, you're going to be taking them, you're going to be labeling them, because you can actually label them. It won't show up on your film, but you'll label them. They'll come up digitally labeled. Black area above and below on the mandible, you're going to see that. Right? There'll be a little black area where you're not getting anything because the mandible's thinner. There's a thin white line apically to the roots on the maxillary recess. So you'll see this like little sinus cavity effectively, and that can help you if you didn't label properly. Because sometimes people are zipping through their x-rays and banging them off really quickly, and they forget to change what it's going to come up with on the digital file. Orient according to above, right? So you're going to actually learn this, that it matters how you orient them. Remember, the dot was at the rostral end of the mouth. And here's a little hint. Know your teeth. You should know your teeth by number. Because when we talk about, 404, 408, whatever number we're using, you want to know which ones are which and how to orient them as such. I'm not going to go over this. We've done this before, and we're going to do it in class, and I have it in your manual. But remember that triaden system. You're going to use that, 1, 2, 3, 4 for your arcades. And we're not usually using any juveniles, so we're not doing 5, 6, 7, and 8 arcades as a general rule, but you will be in practice. But making sure you remember how to number them, right? Remember the rule of 4 and 9 will help. And cats, remember they're missing some premolars. So convex side always faces tube head and at rostral end of mouth. You can't really see it there, but the convex dot is at the front, and the convex side always faces you when reading the film. So you can see it's the same orientation that you took it. Okay. Film focal distance, or SID, source image distance. Traditional film requires that size 2 and under, so a size 2 plate or a size 2 film, you're 1 to 2 inches away from the film. So you're usually right up against the animal's face. You're very close to the face. When you get a bigger plate, a size 4, we need to move that tube head back, and we'll have a 6-inch from the film. Right? You don't have to get a ruler out, but you want to be aware that you're going to pull that back further. And what that it does is it makes that cone, that little focus circle bigger, right? And it allows a wider area of x-rays. And then typically you're going to increase the exposure time 1.5 times. We don't tend to do that because, again, with digital, we have a lot of latitude for our x-rays. Digital film is sensitive enough to not need to adjust that distance exposure. So you can see it gets bigger as you move away. Okay, now, like I said, you're going to realize that there are a lot of rules when it comes to taking teeth. It's not as simple as taking an abdomen where you're like, okay, well, I measure here and I take it in true lateral, and it's always pretty much sort of this, making sure everything is perpendicular and parallel. A lot of teeth, you can't get that because you can't get the film perfectly behind. Some of them you can, but a lot of them you're going to have to learn this thing called the bisecting angle. And that is where you're going to have your tube head, your plate over your teeth, and you're going to split the difference, and you're going to get this angle. And that's what you're going to put your tube head at, between the angle of that tooth and the plate, split that difference, and then you're going to get the best diagnostic view you can get. Parallel technique. Let's start with that one. That one's the easiest. So the tooth is parallel to the film like a limb. This is the easiest. This translates the most to what you've already done. So what we can do, so you can see in this example of some premolars, we can actually, because the mandible has this flexible space, that we can fit a film low enough. Because remember, we do care about the crown of the tooth, but what we really want to see is what's below. And to get a good diagnostic X-ray, we need to have a couple millimeters around all the areas of the tooth to see the pathology that's happening around there. So in this case, we can push that film deep enough into the mandible. So like for 307 and 407 in distal, we can get it deep down. And what that allows us to do is get that film, you're going to use little bits of gauze or paper towel to prop that film up so it's parallel with the tooth. And we're just going to move our cone head so it's parallel, just like we would with an x-ray tube, and take our x-ray. And Bob's your uncle, we should get something really nice. Dogs premolar 3 and distal to it. Cats all mandibular premolars and molars. We can do this. Okay. Easy. That's the one we're going to start with so that you feel confident. Okay, and that's what it kind of looks like. So you can see here the tube head is parallel, right? Because we can actually get parallel, and we can get right down to that root on that. And that's what your teeth kind of look like when you get that view. Okay, that works great for teeth you can place a film directly behind. Not all teeth allow this. Think about a maxilla with a hard palate. You're like, I want to shove this film up here, but this palate's in my way of getting to the root. Uh-oh, now what are we going to do? We're not going to do surgery to make a little pocket to put our film in. We're going to do a different technique. We're going to do everyone's favorite. Get out your protractors. Some people hate this. Some people struggle, right? I know people who I work with who are like, I had such a hard time wrapping my head around this, and other people just get it. So in the bisecting angle technique, you can just see in this picture, you're like, that makes no sense. I'm not even behind the tooth. The tooth is laying flat on the jaw, and we're taking our tooth and we're showing the angle of our tooth. We're showing the angle of our film, which in this case is a 90. The bisecting angle where we put our tube head is halfway between, is about a 45-degree angle. And that's where we're going to take it. And trust me, as long as you're coming directly on the tooth, you're going to get a good x-ray. Right? X-rays are always a bit about tweaking, even parallel. Sometimes you're coming at it not quite directly, so you elongate, or you're looking kind of down the front or the back of the teeth. But it's usually just a little bit of tweaking. But if you set this up perfectly, you're going to see the whole root, and you're going to see the crown, and you're going to get the shot you need. So, bisecting angle. An angle is formed by the intersection of the plane of the film and the long axis of the tooth. So you're looking at the tooth, and trust me, you're going to use a lot of, we have little sticks. You're going to use the sticks in your film to find your angles. If the central X-ray beam is perpendicular to a line that bisects this angle, the resulting image is as accurate as possible. Trick. Think where to stand to find the angle. Some teeth you're going to stand at the front, and some you're going to stand at the side of the head. Now, I'm going to give you a trick now. Start practicing your yoga moves, because to get the best angle, you want to squat down to see that angle. If you go from above and view it, you're going to get a skewed angle. Incisors and canines, so teeth at the front of the mouth, you're going to look at the side of the skull. You're going to stand at the side to get that angle. Right? So in this case, we have a mandibular canine. And you can see there's the film laying flat, and there's the canine tooth. We're going to talk about root placement because you kind of have to know how the roots go. You're going to put, there's a stick there at the tooth. So there are your two angles, and that intersection between them is, see where we're putting our cone head. And that's number size for film, hence why the tube head is pulled about 6 inches away. Now, just a little chat here. Now that I'm seeing this laying on its side, we're going to teach you to do everything in lateral. A lot of stuff out there on the internet, it's handy, but they do a lot of stuff not in lateral, the animals in sternal, and that's not really great because most animals, when we anesthetize them, we have them in lateral. So we're teaching you how to do that all in lateral, so you're not moving the animal around as much. Premolars, right? Stand at the front. So instead of going to the side, you're looking from the front of the animal. If you get this mixed up, which happens all the time, you will get the wrong angle, and it will be very confusing for you. Okay, so in this case, you're still doing the same thing. You can see we've got the angle of the root of the premolars, and we've got the film angle, and then halfway between our bisecting angle in red is where we're putting our tube head angle. If your angle's wrong, foreshortening and elongation happens. Foreshortening, the tooth looks stubby. Elongation, the tooth is tall and long, right? So think about the sun as a shadow. If you see this tree, but if you're walking, right? A low-angled sun in the evening, you get those long shadows. So if you're walking across the lawn as the sun's setting, you look super tall and skinny, your shadow does. If the sun is directly above you, you get a short shadow, right? So if you do foreshortening, if you get your angle wrong and you foreshorten your angle, you get these stubby teeth. And I've seen where students do it so badly, you're actually looking at the crown of the tooth, all the ridges on the tooth, and you're looking through the tooth down, which is not what we want to do. right? We want to look at the side of it. If you go the other way and you make your angle too long and you elongate it, you get these, I call them tall, windy teeth. They're really tall. And if you have the angle from the front or back wrong, it looks like the teeth are like blowing over. Okay. So that's what elongation looks like. Beam aimed directly at the tooth. Too much at the tooth. Okay. Not enough at the film. You get a long image. Look at those tall teeth, right? I know roots are long, but they're not like that, right? Those are elongated. That's not a diagnostic x-ray. Now, some vets would be like, whatever, I can see there's nothing going on, but that is not a diagnostic x-ray. On the opposite side, you have foreshortening. You're aiming too much at the film. See how we're aiming through the top of the tooth, too much at the film? And look at those stubby little teeth, right? They're super stubby. That's because the angle's wrong. Right? Like I said, dental rads can be taken with a conventional machine. Oh, it's terrible. In this case, you need to move the patient, not the cone. It's hard to do when there's a body attached. When it's just a skull like this, easy peasy. Some conventional machines have angle meters on them that work well, that help. Well, most of the time, you have to move this. We used to teach this, but it's a skill we don't teach anymore. Be grateful that that is something you don't have to do. And you'll probably never have to do in class. Okay, so that's it for the intro. We will be looking at the two machines, the CR and DR systems in lab, and you're going to start playing with it, and you're going to tell me which one you like best. You're not allowed to tell me you don't like any of them, sadly, or maybe greatly, happily, if you like dental radiography. It's a very common thing that's in practice now. All right, until next week, take care.